substantial variation which is site specific from brain to the lower spine. Looking up to the brain, the maximum deviation is going about 0.3 centimeter, and in the middle spine it's crossing 0.3 centimeter, and in the lower spine it's even touching 0.6 centimeter. Systematic and random errors also show a similar pattern which have an increment in nature from brain to the lower spine. From this, I have obtained my PTV margins which have increase in nature from brain to the lower spine. This graph shows a clear picture of my result that the green line shows the values of lower spine which is higher in nature, followed by the orange line which shows of middle spine and a low value for brain. So to finalize from this, for brain we can give 3 mm margin, for the middle spine we can give 5 mm, and for lower spine we can give 7 mm margin. These are the studies which show a similar results to my study, that cerebral increases in the caudal direction of the spine with implications for differential set of margins for the brain, upper and lower spine targets. So, to conclude from my study, using a non-symmetrical PTV.
A very good afternoon to one of our present here. I am Sandhya, Internal Medical Business from SRMS IMS. Today I will be discussing treatment planning. I will start my presentation with a brief introduction. In modern radiotherapy, precise dot modulation is achieved by MLC, where it plays an important role in target conformity and normal tissue sparing. The use of Millennium MLC and HDMLC enhances the plant quality greatly. However, the field size limitation of HDMLC restricts their applicability in breast fields, and it also complicates the direct plant conversion from Millennium MLC to HDMLC. So, the aim of the study is to evaluate the dosimetric impact of MLC refit, so Millennium and HDMLC in IMRT treatment planning for breast carcinoma. The main objective of this study is to determine the feasibility of direct plant conversion from Millennium MLC to HDMLC for large breast fields, and also to generate re-optimized plants for the fields which cannot be directly converted from Millennium MLC to HDMLC, and to evaluate the target coverage, dose conformity, homogeneity index, OS pairing and normal tissue doses for these two plants. This study includes 18 breast cases. For each cases, 3 sets of plants were created. The first set is with Millennium 120 MLC. The second set of plants are directly convertible plants from Millennium MLC to HDMLC. The third set of plants is for the variant Trubin machine for both Millennium and HDMLC. For Millennium MLC, the field size is 40 by 40 cm square. For HDMLC, it is only 32 by 22 cm square. All these plants were evaluated for PTV coverage, normal tissue doses, and OAR sparing. The beam parameters such as beam angles, number of beams, and all the constraints were kept identical for all these 3 sets of plants. So the results are tabulated for all the evaluation metrics. For the PTV coverage, parameters such as conformity index, homogeneity index, maximum dose received, and volume receiving greater than 53.4 grid. That is 107% of the prescribed dose is tabulated, and student paired t-test was kept as a statistical analyzing tool here. So the plants of set 1 and set 3, that is Millennium and HDMLC, were compared for the p-value, and the results are tabulated here. The set 2 is directly convertible plants. Only few samples we could get, so only mean and standard deviation to the set 2 plant is tabulated here. Next is OAR. For the structures heart, spine, esophagus, right and left lung, and contralateral breast has been analyzed, and their results are tabulated here, with a mean and standard deviation for the set 2 and p-value for the set 1 and set 3. Normal tissue doses were analyzed by assessing the volume of 2.5 gray receiving volume, 5 gray volume, and 10 gray receiving volume. Their results are also tabulated here. All the plants created by Millennium MLC and HDMLC shows clinically acceptable results, but no statistically significant difference was observed between these Millennium and HDMLC in target coverage, OAR doses, and normal tissue doses. From this, we observe that direct Larger fields require a 90-degree collimation rotation, which is equivalent to a double isocenter technique, leading to higher MUs but avoiding isocenter alignment setup time. Despite higher MUs, no dosimetric change was observed, showing this method suits center without dematched system and also different emulsions. From this study, it is concluded that HDMLC based IMRT plants shows negligible dosimetric variation over Millennium MLC plants, confirming that MLC leaflet has minimal impact on target coverage, OI doses and normal tissue doses. Thank you all. Thank you for listening.
Thank you, Sandhya. So your conclusion is applicable in generic to all sites or only for breast where there is a larger?
Applicable to all sites, but I have only studied for the breast cases or other cases also I included in future studies again.
I think you should revisit that. Then the ISO center, what you kept for all the two, were of the same level or it has to be changed because of the training or the field size limitation?
It has been changed. Yes.
Impact of virtual bolus positional uncertainty in radiotherapy planning, a phantom study. Bolus material is used to bring radiation closer to the skin, especially for tumors near the surface. However, identifying the need for bolus during imaging can be challenging. But our treatment planning system offers the concept of a virtual bolus that can be added even after imaging. But the challenge is replicating the virtual bolus position on the patient's skin accurately during treatment delivery. Aim of the study is to evaluate the positional uncertainty of the virtual bolus and its dosimetric impact in radiotherapy planning. For this study, the study was initially conducted on non-clinical scenario. For that, uniform geometry phantom is taken of 30 by 30 by 8 centimeter cube water equivalent phantom with a 5 by 5 centimeter square bolus and 10 by 10 field size and with a 6 MV photon beam. And the placement of bolus is shown in this figure. From this non-positional error of 1 mm up to 5 mm were introduced and dose measurements were taken. And the study is also performed with the CR head phantom to mimic the clinical scenario. For that, CR head phantom equipped with the pharma chamber were scanned and imported into the Eclipse TPS, and chamber volumes were contoured, and 10 head and neck IMRT plants were with incorporating virtual bolus were created and measured the mean chamber dose. The same setup was positioned on the treatment couch using CBCT. For each case, it took 3 trials of CBCT to exactly match the position of the bolus. And also, surface dose measurements were also measured by using EBT3 film placed under the periphery of the bolus with a non-3 mm shift in the bolus position. And from the homogeneous phantom, it shows less than 2% deviation, which is not significant. And from the heterogeneous phantom, at the isocenter level, there is no significant dose difference were observed. But at the surface, significant difference were observed. For megavoltage photon beams, the percentage depth dose curves becomes relatively stable beyond Dmax, which means small change in depth will cause insignificant dose variation beyond Dmax, but the addition of bolus will highly impact on surface dose due to high dose gradient between surface to Dmax. But at the isocenter level, it is negligible due to attained CPE. And the study concludes that misplacement of the bolus can result in significant variation in surface dose, potentially leading to either overdosage or underdosage, while the dose at the isocenter remains less affected. Therefore, it is essential to ensure precise and reproducible placement of the bolus to optimize treatment accuracy. Thank you.
Thank you. It will be insignificant, but at the surface it will be.
Yes, sir.
So what is a good dosimeter to measure the surface dose for this thing? Because you use only ion chamber measurement. Is that right?
No, sir. I used film also for surface dose measurement.
Jephromic film. Jephromic film.
Yeah, EBD3 graph chromic film.
And bolus was kept above that.
Yes, sir. Bolus was kept above that.
But the nano dots may be a better idea to use that, because again there can be surface air gaps and other things.
Yes. But
and how do you ensure the bolus placement? Your end point was that you have to ensure the bolus placement. So how can you ensure it in a clinical situation?
So we can go for 3D printed bolus. That is a better option. But every institution may not have that facilities. So better reproducible. We can go for standard geometry of virtual bolus. That will be more easy to reproduce.
Virtual bolus, which is a little gel in nature to take the contour of the patient.
Yes.
Okay, thank you. Because 3D printers will have a disadvantage. It will be static printing, so it will not take the shape of the day-to-day variation of the breast. Because sometimes intact breast that can vary day-to-day a little bit, few millimeters. So many times we find 2 millimeter gaps in between bolus at some location.
Yes.
That is a practical challenge.
Thank you.
Good afternoon, everyone. My name is Devansh, and I'm a student at HCBGA. So my study is a pilot retrospective study about the dosimetric and workflow advantages of SIV over the sequential boosting breast radiotherapy. So the breast conserving surgery followed by radiotherapy is a standard for early breast cases. So we can go for two ways we can treat this. One is the sequential boost and the other is the therapy first, then we are going for the post radiotherapy. Whereas in the SIV, we are delivering both concurrently. So why we have choose SIV over sequential boost? So which is the time and efficiency. The sequential boost we are delivering in 4 weeks. That is our breast plus boost, and the SIV technique we can deliver in 3 weeks. That means 1 week shorter. That means we can treat more patients for the during this time. So my objective is to compare the dosimetric and workflow outcomes between our hybrid plan technique for SIV and the conventional sequential boost technique for hypocapniated radiotherapy. So we have chosen 10 post-breast conserving surgery cases, including both left and right breast cases. We are using a variant Eclipse DPS and a proving with a Millennium 120 MLC machine. So we are going for a hybrid approach, combining both 3D CRT and a VMAT for post. So the dose prescription we have used is for the sequential, we are giving 40 grain 15 fraction for the whole breast plus a 12.5 fraction for the post volume. Whereas for the SIP, we are delivering 48 grain to the post and 40 grain for the whole breast, then in 15 fraction. So the initial plan was to for the whole breast, which we use for a 3D CRT technique with the feeding fluid. And in the next step, we have choosing this 3D CRT as a base plan for the post VMAT plan, and we are using a short VMAT arc, each spanning around 30 degrees, coupling with the non-coplanar beams. That means we are giving some couch angles. And the result that we found is that conformity index for the SIB plan was way better than the than the sequential boost. We got a comparable homogeneity index for the sequential boost and SIB. But the problem was that the OAR dose was more in SIB compared to the sequential. So this is a dose distribution of the post sequential and SIB. So here you can see that the 95% of the dose in the sequential boost is more spilling out of the tuber volume, the boost volume, whereas in SIB it is more confined to the PTV. So here it is a diagram of the low dose spillage. Here you can see the low dose spillage is more in case of the SIB. So the
conformity you have to handle.
The conformity to the boost volume includes the postmasis effect. That means the in aesthetic outcomes, the SIB was better than the sequential boost. Whereas our concern is the lower dose and low dose spillage. So for that we need further optimization of the treatments. We are currently in learning phase for this thing. And one more concern is that is the IGRT protocol. So we have to be more stringent about this protocol when we are delivering SIB cases. So we have got in the conclusion we got a better conformity and a comparable homogeneity, but an increased OAR dose for the SIB. For this, we have to further develop our hybrid planning techniques so as to reduce the OAR dose. Then it will be easier for us. If it is laterally or medially placed, the hard dose will be more compared to the
And one suggestion, when you show a dose distribution for any breast, it's always better to show an axial slide on the heart. Heart will give a dose distribution which is comparable between two techniques.
This is only shows you the lung using, but not the heart.
Because in breast left side dose distribution always we have to be close to the heart to see what is the heart dose. Because no dose to heart is recommended, but still we will have dose to heart. Thank you.
The STOOP trial, for which the pragmatic standard of care is established for GBM for conventionally fractionated radiotherapy. However, the prolonged overall treatment time combined with the intrinsic radioresistance of glial cells poses risk for tumor repopulation and poorer outcomes. Therefore, it made us well into the study question that can the OTT reduction with a radiobiologically equivalent RT schedule improve outcomes without compromising the toxicity or the quality of life. Therefore, we aimed to compare the efficacy and feasibility of our study arm, that is the hyperfractionated RT schedule at 52.5 gray in 15 fractions at 3.5 gray per fraction delivered over 3 weeks versus our established standard of care with the following endpoints. It is a single center prospective randomized controlled study with actual still ongoing, and we have analyzed 21 patients so far with the following inclusion and exclusion criteria. This was a consort diagram which showed that we screened 24 patients for our study. However, 3 were excluded due to various causes. 2 patients in our study arm are still on chemotherapy follow-up with 6 deaths, and 3 in our control arm are on chemotherapy follow-up with 5 deaths. However, all were included in the analysis per the intention to treat protocol. We did the contouring using the EANO guidelines, and the toxicity assessment was done using the CTCAE version 5.0. The follow-up and response assessment was done using the clinical and the radio functional imaging using the RANO criteria. The quality of life assessment was done using the validated questionnaires with appropriate statistical tests using the intention to treat method. When we come to the results, almost all the baseline characteristics were equally balanced between our study arm and the control arm. However, the residual tumor size more than or equal to 4 cm was slightly higher in the HFRT arm. Also, we can see that an established risk factor, that is the gap between the surgery and RT, slightly favored HFRT arm, trending towards significance. Also, subventricular zone, stem cell niche for the cancer stem cells, known factor for dismal outcome. The percentage of cases for SVZ contact cases were balanced between both the arms. We can see that the median follow-up was 10.25 months overall, with 7.82 months in the study versus 10.25 in the control arm. And we can see that on the follow-up status, death due to disease cases were almost equally balanced between both the arms. And when we see the response assessment 3 month post-RT and 6 month post-RT, we haven't included all patients since some patients have still not completed the entire course of chemotherapy yet. And also some patients had expired before the radiological assessment could be done. Although the early results favor that there is a trend towards a better response towards the study arm, but longer follow-up is required for this. And as the toxicities are concerned, neurological toxicities, on the contrary, grade 2 and grade 3 were slightly higher in the CRT arm, which is not as per the radiobiological rationale. However, this was probably due to the shorter follow-up and the early deaths in the HFRT arm.
Possible further to compress your RT schedule?
Ma'am, as far as the early outcomes are considered, and as and when I have seen the 6 month OS and PFS as well, for now I would try to keep it at 3.5 gray per fraction itself, and also owing to the radiobiological equivalence of the two arms, so I would prefer not to hypothesize
advantages, and they have complaints of pain dysphagia, foul odor, and which is a short and effective and well-tolerated treatment regimen. So in this study, we found out we validated the quality of life, overall survival, progression-free survival. In this study, we took histologically proven SCCs, unresectable head and neck, locally advanced head and neck or metastatic head and neck cancers, and all of them ECOG was 0 to 3. In this, we gave radiotherapy with concurrent cisplatin, and as in quad-shot regimen, per cycle we gave 14.8 gray in 4 fractions in 2 consecutive days, 2 fractions per day, 6 hours apart. And we gave this dose to the PTV, which was formed by taking GTV with 1 centimeter margin. Cisplatin was given at 100 mg per meter square divided over day 1 and day 2. We repeated this for 3 cycles every 3 weekly, only if there was no progression of the disease. We treated it using VMAT technique on a 6-assembly lineup. The quality of life was assessed using a validated questionnaire URTC QLQ, C30 and head and neck C35. So this is the treatment flow, and we found out we took a total of 28 patients. The treatment result was that all the patients completed quad shot 1. Quad shot 2 was received by 53% of the patients, and quad shot 3 was received by 39% of the patients. And we found out that the median progression-free survival was 3.61 months, median overall survival was 5.68 months. 75% of the patients who completed all the quad shots had effective palliation, and 29% of them showed complete radiological response. In terms of quality of life, there was significant improvement in pain, dysphagia, and trismus after a single quad shot cycle, and which continued with the completion of third quad shot cycle. And there was also improvement in the global health score. So here in this image, we can see a drastic change in the visible clinical difference after quad shot 2 only. Discussion, we found out that quad shot with cisplatin is a feasible and well-tolerated regimen, and we might likely reduce the acute toxicities. QLQ quality of life assessment was done using a validated questionnaire, and the results of the study was comparable to the CORIS trial, but addition of cisplatin is unique. We concluded that this RT schedule is short, simple, and well-tolerated. It gave rapid symptomatic relief, and quality of life improvement was seen in most of the patients who received even single quad shot cycle. And a larger randomized study is recommended for validation of the study. Thank you.
Thank you. So, but did you find any problems giving it? I mean, introducing the next quad shot for the patient?
No, ma'am. Those patients tolerated the cisplatin well, and the toxicities were manageable and were within grade 1 and grade 2.
With cisplatin?
With cisplatin.
And you'd like to repeat it?
Yes, ma'am. We gave cisplatin in all the 3 quad shots, not just first quad shot.
Any neutropenia or other
And it was within grade 1 and grade 2 and didn't require any hospitalization.
It's an effective way of palliation.
Yes,
So
sir.
my question is that when you wanted to do second and third cord shot, do you need to do palliative section?
No, sir. We will require doing the re-RTP because there is a significant change in the tumor volume.
Change in volume.
Yes, sir.
Then the other question is, any specific reason for number of patients in quad shot 2 and 3? Because there has been a drop of patients not having third shot. Reason for that?
Sir, 9 patients had death related to the disease, and there was a loss to follow-up also of the 4 patients. Thank you.
I'm presenting a topic regarding precision-guided treatment for a high-risk diffuse infiltrating retinoblastoma. It's a rare case. Retinoblastoma is the most common intraocular malignancy in children, and it's caused by the RB1 gene mutation, and it's a rare type because it's the diffuse infiltrating variant. And it's a case history and 7-year-old girl with 8-month history of progressive symptoms of right vision loss with redness, watering, and annulus staphyloma. There is no light perception, secondary glaucoma, and hypoma. On investigation, we performed the MRI of the child. In MRI, it shows the total retinal detachment with the intraocular tumor. There is no intercranial extension, and there is no optic nerve invasion. And B scan performed, which shows the intraocular mass with the high internal reflectivity. And this is the MRI finding. And because in MRI there is no optic nerve involvement, we suggest the child to the enucleation process, and child underwent the right eye enucleation with the gold eye implant. After the enucleation, histopathology report came, which shows the diffuse infiltrating retinoblastoma, which is the poorly differentiated, and it's a rare variety, 1 to 2% only the diffuse infiltrating type. And it shows the choroidal invasion and also sclera and extrascleral involvement, and also post-laminar optic nerve invasion also present. And we advise the child to high-dose VEC chemotherapy as well as the adjuvant VMAT radiotherapy. Then while radiotherapy planning, we compared the 2 plans, 3D CRT as well as the VMAT plan. In the first figure which shows the VMAT planning, and the second figure which shows the 3D CRT planning. And while comparing the DVH as well as the planning treatment volume and the homogeneity index as well as the conformity index, it shows the VMAT is preferred, and VMAT shows the conformity index 0.78 as compared to the 3D CRT 1.01, and VMAT shows the homogeneity index 0.18 compared to the 3D CRT 0.24, and also OIR sparing also, which is good in VMAT. And this is the brain volume receiving the radiation doses in VMAT and 3D CRT, which shows in V10 and V15 there is significant brain sparing as compared to the 3D CRT. And the p-value also significant. While discussion part, VMAT achieved the better dose uniformity as well as the conformity as compared to the 3D CRT in our case. And also, VMAT appears to be safe and more precise adjuvant radiotherapy option in high-risk diffuse infiltrating retinoblastoma. And while conclusion, high-risk diffuse retinoblastoma, which require the adjuvant RT, and VMAT provide the better conformity as compared to the 3D CRT. And also VMAT reduces the low dose exposure to the brain while comparing the V10 and V15 of the brain. Lower brain dose may reduces the long-term neurocognitive toxicity also, and therefore VMAT should be preferred for high-risk pediatric retinoblastoma case. Thank you.
What is the ideal treatment of choice for this kind of treatment?
Sir, ideal treatment, this is a rare variety and high-risk infiltrating type of retinoblastoma. It should be followed the regime like chemotherapy and adjuvant radiotherapy after the enucleation of the
Regarding radiotherapy, RT, like any ophthalmic applicators, strontium 90, any other eye applicators which you can use, strontium 90, beta emitters.
What's the normal application?
Yeah, now the next point is that what was your MLC size and daily image guidance, what did you use?
Sir, ideally can be used for the preservation of the
reason for comparison of 3D CRT? Any specific reason? Yeah, that's what I exactly asked. Because VMAT will be a desirable option with very high precise relocating, because we have to do 25 fractions larger setting, though the positioning and the 60 couch and other things will be very useful. Okay, thank you.
Thank you. So the next candidate is Dr. Fatima.
Good afternoon, respected judges and colleagues present here. The topic we'll be discussing today would be the bigger the bread, the safer the heart. It will be a correlation of geometric and dosimetric parameters in DIBH-based radiotherapy for left-sided breast cancer. So, the background and rationale for my study would be cardiac toxicity remains a key late effect after left-sided breast artery and anthracycline therapy. DIBH increases lung volume and separates the heart from the chest wall, reducing heart or LAD doses by up to 50%. We'll be measuring the geometric surrogates and it may help in predicting dosimetric sparing. The geometric surrogates which we suggest are CLD and CST, that is central lung distance and central heart distance. So, if you can see in the left side, that is DRR and free breathing, the blue dot, it depicts the CLD and the red arrow that depicts CST. If we see it in the right side, the tangential line, it moves towards the chest wall, that is during DIBH, what happens? Lung expands and heart becomes tubular. It moves inferiorly and posteriorly. Thus, cardiac sparing can occur. The objective for my study would be to assess correlation between parameters, that is DIBH amplitude, central lung distance, maximum heart distance. And we studied the clinical dose to organ at risk, that is mean dose to lung, heart, CAD, opposite lung and opposite breast. Volumetric doses were also calculated, including ipsilateral lung, that is V20 and V5 of the ipsilateral lung, contralateral lung, heart, and opposite breast. Material and methods. It was a retrospective analysis which was done between January 2024 to July 2025. 22 patients with left-sided breast carcinoma were taken and DIBH VMAT was performed. Pre-simulation coaching for 3 to 5 days were done and parameters assessed were CLD, CSG, DIBH amplitude, PTV, heart and lung DBH. We basically analyzed correlation between geometric and dosimetric indices. Observation. CLD showed positive correlation with ipsilateral lung mean dose. DIBH amplitude and CSG, they showed no significant correlation. No significant difference in dosimetry between IMC versus non-IMC and BCS versus MRM drugs. If we see this graph, this flat curve suggests DIBH amplitude alone does not predict heart mean, as its effect negated by the VMAT. In this graph, if we see between the representation between amplitude and mean LAD dose, still a flat curve which suggests DIBH amplitude does not alone predict LAD. Interestingly, there could be some other factor that would be affecting. Amplitude versus mean ipsilateral lung dose, there was a higher amplitude if we see this graph. And all of the parameters that we measured were under the constraints required, the recommended doses. The results and interpretation, DIBH markedly reduces mean heart and LAD doses without compromising the PTV coverage. CLD showed strongest correlation with lung exposure, and CLD can serve as rapid geometric predictor during coaching. The practical recommendation after the study, what we get to know is amplitude alone is not a predictor for cardiac sparing. And we can use CLD and CSG during respiratory coaching to anticipate dose spreads. It helps minimize unnecessary CT scans and streamline workflows. The key clinical takeaway from my presentation would be CLD or MSD would be a simple, reliable, geometric predictor of pulmonary and cardiac dose in DIBH settings. Consistent organ sparing is achievable across all kinds of surgeries, that might be MRM or BCS. And the amplitude monitoring, everything is reproducible. Moderate DIBH is preferable. The conclusion is DIBH-based VMAT ensures significant cardiac and pulmonary dose reduction. Thank you.
were expecting?
When I started the study, I was actually just looking for amplitude. If amplitude could suggest something. But when I couldn't get anything, I included other parameters like CLD and CLD, which was due to another studies. Yes, so we do that switching gating from based on the RPM. When we take the patient prior 3 to 5 days prior to the RT, we ask the patient to hold the breath. Yes. No, sir, it's not consistent. For every patient, it's different. If I could frame it in a single sentence, I would say that it's not how big of a breath you can take, but how consistently anyone can take it.
So you're saying very clearly the amplitude doesn't have a relevance for heart management. But what could be other compounding factors which should be relevant?
But the other compounding factor, amplitude does affect, but because of different geometrical and artificial.
Amplitude, we cannot say that the heart rate is bad or not. So the other one is the location of the PT.
Yes, sir, the PPE coverage, the location of where. That is what the study was sketching down. Yes, sir. Thank you so much, sir.
So that could have been also talked about.
Yes, sir. I am planning to further continue the study.
Concordance among pathologists, that is reproducibility in identifying multiple. When there is poor unterminated, there is low. When the copy number is high, there is low mutation rate. There is poor.
Look around camera. Wait. Look at man, camera, look at.
Apart from diagnosis, Dr. Puna Gupta is not here, we'll give a right, ma'am.
Look at man, camera.
Chaturvedi. Thank you for coming.
Hey man, look at hello. Okay man. Wait. कर रहा भाई लाइट हम और चढ़ जाएगा लुक एट सर कैमरा इसमें
and probably a few other centers are present, but I have no experience with respect to credit.
Okay, thank you. So for students, SBIT we are giving surgical option is there, that is okay. But brachytherapy is also very important tool you have for treating these cases. So you should always consider for that. Thank you.
And it's a good tool and they find minimal toxicity and complications are early.
Hyperfractionation, especially extreme hyperfractionation in high-risk patients.
We have been using extreme hyperfraction in high-risk patients, and in this center where I am working presently, I have not utilized it. But in Tata Kolkata, we were doing DNA out, and we were using 36 grade pipe. I was in part of Dr. Indra.
Regimen combining 5-FU and mitomycin C. This new adjuvant visualize the tumor and surrounding.
Look at sir. Look at sir.
This means we can adapt the plan on the basis.
We reminded of the importance of brain in canal cancer.
The Pavlov technique was there, but it is
contours and the dose distribution. So brachytherapy is very important part for radiation oncologist.
And these tumor responds to immunocheckpoint inhibitor. Now, how do radiation therapy act? As we all know, with radiation therapy, there is immunological cell death, the 6 like chemokines, cytokines, DNA damage repair activation, HIF, of immune inhibitors on the T cells. These immune inhibitors are CTLA4, PD1, TIM3, VISTA, LEF. So we had done a study in our institution radiation, and we have found that post SBRT there is an increase in PT1 and lab-free.
Any chance of combination of surgery and radiation?
Yes, sir. There are studies by Yoon et al. And Lee et al., which was published in 2020, where we have used SBRT earlier, followed by surgery in a neoadjuvant setting in patients with PETT, that is portal vein tumor thrombosis. However, there are few studies coming which have found SBRT as a bridging therapy also. Like for HCC, TACE, microwave and RFA, they have been used as a bridging therapy and downstream therapy. Now there are trials which have found that SBRT can again be used as a bridging as well as the downstream procedure, and that is why SBRT has been included in the recent DCLC guidelines, which is published just 15 days ago. So again in that paper they have found RFP and SBRT are equivalent for HCC patients. So actually, sir, the point is that with what intent I am giving the treatment. If I am treating with a curative intent, then size of matters, like 5 to 7 centimeter, where we can give very high ablative doses and 50 gray in 5 fraction. However, if my intent is immunomodulation before is immunocheckpoint inhibitors, then the size doesn't matter. Even treating a small portion of the disease result in immunomodulation, in turn resulting in improved survival with A+B or TKI. So our intent also matters, with what intent we are going to.
And here again is the role of brachytherapy palliative treatment for cancer.
Treating the patient of HCC depends on the size of the lesion, number of the lesion, location of the tumor, and the viscolarity. So depending on the size, if the size is small, then we can easily target the tumor with brachytherapy. Then the brachytherapy versus RFA or microwave is the option, then either can be done.
At your center, are you doing this?
No, sir, we are not doing brachytherapy because we have a full-fledged IR department where they are treating the tumors by microwave, RFA, electroporation, and etc.
Okay, thank you.
That's the process. So, you have just shown there is a you have to give all formality, and then you can that is by process technique you can cure the patient. So why not you do often after this any study often these two process technique, and then depending on the histology we proceed further.
So because bladder cancer, most histologists they are on the principle of this field cancerization. So we just cannot target only a selected area of that bladder from the first, for the very beginning. In the tetramodality therapy which I told, you have to sterilize all the bladder mucosa with use of radical chemoradiotherapy upfront. Whatever is left out or whatever was the dominant part of that tumor, you can consider of taking that out afterwards. So it's kind of the concept of field cancerization, and you have to sterilize all the areas for the treatment as well. That's the case on this side.
Present to us, if you see a patient with a radial cystectomy coming to you, you see how poor is the quality of life. Day-to-day life is becomes very difficult, and post-op care is again very important. And so far the outcome is concerned, that is also not a very different, and age of the patient is important. So considering all these things, radiation becomes the treatment of choice. But then to convince in the tumor board is a difficult job. When the surgeon is in front of you, they will say, yes, I will remove everything, and you are not able to convince that, no, here probably the treatment choice will be radiation with chemotherapy and all this modern immunotherapy, and that will be giving a better quality of life to the patient of this elderly age group and of these conditions. So how to do that? I mean, that one has to think, especially radiation oncologist.
The problem is that the first time we don't have a randomized comparative trial between radical cystectomy and the trimodality therapy, whichever we are talking about. That is the first problem. So whoever gets the patient first probably will treat the patient. That is the first thing. Second thing is, most of the time the patient is not seen in a total, as a human being probably, because most of the time they are not counseled about the side effects properly. Maybe radiation, maybe surgical. So that is what I mean to say, that we have various options for the patient for these treatments. So we must offer them to the patient and then let the patient choose whatever he wants. Most of the time the patient might tell that just I want to get rid of this disease or get this out of my body. And sometimes considering the quality of life, he may choose the trimodal therapy as well. Even the outcomes are pretty similar in both the conditions.
You are right. But first thing is teammate.
Sure.
Because you see the totality. You see the totality, how their quality of life deteriorates, how problem they have to face. And so if you leave it to the patient, because they don't know, they are ignorant of many aspects. And they, of course, their general feeling is, if it is removed, then alright. If a surgeon will tell them, I will remove that disease, then you will be alright. But you will not say. As a radiation oncologist, you will always say question mark, okay, it can be alright, it cannot be alright, you may have problem, face this problem. They don't tell the problems after surgery. So, here in the team, we have to understand the things and give what is good for the patient. Leaving the choice of the patient is a bit difficult sometimes, many times. But they don't know many things. In fact, they follow what you say and how convincing you are. Okay.
Possibly I will make all this trimodality treatment myself and
in our clinical practice, all this muscle invasive bladder cancer, we usually
2 to 3 years I have seen one patient. So these are anecdotal, but still this is also a possibility. The bladder can be preserved.
Which is here, you are comparing radical cystectomy. Of course, I am a medical oncologist. I am in between radiation and surgery. Comparing radical cystectomy, single modality with trimodality here. Is that true?
Yes.
Ask a surgeon to give him immunotherapy, chemotherapy, followed by radical cystectomy. Then you call it a day. Without comparison that a single modality versus trimodality. Any surgeons in the hall?
Sir, may I come in, sir? Sir, it's not exactly only single modality, because these days radical cystectomy is supplemented with neoadjuvant chemotherapy in most of the cases, because it has become standard of care. Firstly, and secondly, there is an option of even immunotherapy in adjuvant setting after the radical cystectomy in these patients. So these.
Sir, look here, sir. Okay.
Dr. Deepti Sharma.
Look here, sir. Okay.
Dr. Avardeep Datta. And please pray for his healthy and early relief of the symptoms.
Look here, sir.
Lieutenant Dr. Co-Organiser and panelists. And another panelist is Dr. Saurabh Mishra.
And the ovary has been far away from the uterus. So, and that is my point of view. That
and slightly different with respect to the like it is around 16 to 20 gray even when we give around what is known as we try to give during the pelvis. When we are giving breast cancer we are going to like radiate the ovaries, so it is around 16 to 20 gray, and your dose in such cases around 50.4 gray, which is normally is a long term. I think the dose to the ovaries is very less. In the field around the pelvic nodes, difficult. I think it will definitely lead to permanent sterility, and as sir has mentioned, I totally agree that there are very few cases, and probably in the literature how many, probably very rare, and there must be, I don't think so there is dearth of information to that, but definitely
ovarian transposition in each cases or not?
I don't. So, Dr. Alok, everything is okay. How much you are able to counsel the patient for a surgery for transposition?
No.
That's
so in our experience, we have done in 4 cases, and we don't had any big issue in these patients because everyone is willing to have a baby. Okay. So if you have, there is emotional catch for them. And this surgery doesn't take much effort. It is just a simple laparoscopic procedure that you can finish within a half an hour to 1 hour. So yeah. So laparoscopic.
The thing is, in this context, the radiation dose is 45 to 50. Ovary to blast ovaries, less than 50% of dose spillover is sufficient to blast. If I am sure, 1 fraction of 6 gray is more than sufficient to knock down the ovaries. So the spillover, how much in spite of our, the best contouring, probably the spill is more than sufficient. I think ovaries, the high chance of knocking down. Okay. But coming to the endometrium, but whereas in case of ovary knockdown, very high chance of 90% you can say they are out.
So obviously we want to preserve ovary not only for done the LAR after that, and with covering stoma. Most of the patients in mid rectum or lower rectum, if they are radiated, we normally go with the LAR with the covering stomas. So now one approach is, if you have any kind of insight about the wait and watch approaches where patient want organ preservation, what is your take? Is it actually we are practicing in India or just we are discussing it?
We 6 weeks once the treatment is done, we get the MRI, or probably if you look at the other trials, some say it is at 8 weeks. You can get it, or you can get it by 12 weeks. So it all depends upon what is the initial assessment, what is the follow-up, how you want it to. I think it's more of a surgical.
So even in UK,
counter. So the next category is best paper in the category of SR. Winner is Dr. Alauddin Ansari sir.
सामने देखिएगा.
Now Mrs. Anna Roy, she is in faculty first prize.
इधर देखिए कैमरे की तरफ सब लोग.
Kindly come on the dais.
सामने देख सामने देखिए सब लोग। वेट। वेट। ओके। सामने देखिए।
मैडम सुरभि को बुलाइए देर से
अरे आइए जल्दी आइए, हम देखे ना, हम तो चले गए। नहीं आइए हम भी देख रहे हैं।
सामने देखिएगा।
पहले आप खड़े
नहीं हुआ है।
सब लोग सामने। सामने देखिएगा। सब लोग सामने देखिए।
Printed one for you.
वेट। ओके।
तो नहीं वीडियो बाबू।
सामने देखिए आप लोग। मैम सामने देखिए आप लोग।
And you have to keep on giving exams. Dr. Hadi Rahat, Dr. Mehmoon Khan, Poonam Gupta, Shretima Chaudhary. But still it will start working within 1 or 1.5.
ओके।
कट कर रहा है।
उनको सेंटर में या तो बैठ खड़ा करवा दो।
लुक हियर सर।
बोलो साइड में।
लुक हियर मैम।
और सर सेंटर में आइए सर, सेंटर में चारों का खींचो।
ये देखो देख रहे हो। आंटी सर
हम बात कर रहे हैं।
There is one person who is related to all of these things, okay? And the drug which is shown is used for the treatment of that disease.
Next question. So this given image of the international non-profitable कुशेखर आपको किस कैंसर या किस साइट से रिलेटेड है और उसकी कंट्री ऑफ ओरिजिन क्या है? Next, this Indian author and filmmaker publicly chronicled being a woman. Who is she and what was the diagnosis? Once upon a time this picture was so famous. So सेलिब्रिटी का नाम बताना है, व्हाइट शर्ट वाला बंदा कौन है और क्या स्टेप लिया उसने डिजीज से रिलेटेड।
was your on this?
वो साइड से एंजेलिना जॉली ऐसी नहीं लगती। तो इसके साइड पिक्चर्स ढंग से चेक नहीं करे। So 1942